Ron, I want to respond to your idea about, I'm sorry, I'm Galen Marshall from the University of Mississippi. Your idea about bringing the CSF experts, first of all, I applaud you for recognizing exactly correct thing. That's your many years in medical school education, is that we are trained in different ways. We think of it, of the same thing in different ways. It's the parable of the 10 blind men describing the elephant. But let's go back in medical history 40 years ago, and we would bring a cancer specialist in. We would bring in a patient presents with a shadow on his chest X-ray, and we bring in a radiologist, and we bring in an oncologist, and we bring in an infectious disease specialist, and we bring in a pathologist. And at that level 40 years ago, what they would finally do is figure out a way to get a piece of the tissue, and they would agree, yes, it's a cancer. But was it a primary lung cancer? Is it metastatic breast or colon or other forms of which we now know the approach to effective therapy is quite distinct? There are some commonalities, certainly, but it's quite distinct, as evidenced by the fact that in all the major cancer centers, they don't have primary medical oncologists. They have breast oncologists. They have GI oncologists, and so on, because the approach to therapy is distinct. The anxiety about that approach that you propose until we get better at clinically classifying them, and the lady sitting next to you is probably, if not the best in the world, most of us would agree is one of the top people in being able to do that. Feed her a couple of glasses of wine and get her to talk to you. Get her to talk. Well, I've sat there and listened too.
I knew her when she was a young assistant professor in internal medicine.
I understand that. The point is that in times of candor, we recognize that the spectrum of this illness is now increasing as we learn more about it, whether it's viral etiology, whether it's immune dysfunction, whether it's societal, psychological issues. As we learn more about this illness, the spectrum gets wider. It doesn't get more narrow. So I say this in a way to ask you the question, and really to ask Nancy to comment as well, is do you think we are at that level? Clearly what you're talking about being able to do as a basic scientist is absolutely spot on. And this is really going to be important because of this XMRV thing that is coming up now, and other agents are going to come behind it. I don't think any of us think this is the last one. As we approach this, unless we can relate it back to that spectrum of clinical presentation, how are we're going to miss the answer for so many of these patients that are suffering because we're going to go down the wrong pathway. You don't treat breast cancer with a colon cancer protocol because it doesn't work. But breast cancer therapy for breast cancer works very well, yet they can both present primarily with a lung metastasis that shows up on chest X-ray. I know you know where I'm going with this, but I really like your comments.
Oh, boy. That's like a miracle. I mean, our medical system isn't designed to do things like that. Which I don't think, there's no answer. I don't have an answer to that question. And I don't know how much longer it's going to take for our society to grow to think like that. We just don't think like that.
But I think we have biomarkers. I think that's what's been evolving is we have biomarkers. So, I mean, obviously, you're not going to treat an XMRV positive patient without an assay that convinces you they're XMRV positive. And that biomarker needs a little work still. But it's coming. And it's coming. There's a lot of really brilliant minds going after that. It's fantastic. And if you're not going to treat a person with an immunomodulator, say you use a TNF inhibitor, you're not going to do that unless you measure the TNF biomarkers as being elevated, and then you have an obvious target. So we come down to subgrouping. And if you have a big, messy epidemiologic data set, you can subgroup by symptom and severity and all the things we've been doing for years. But you can also, because if you have the stuff in the freezer, come down to, and which ones were the more immunologically activated, which were the ones more that showed more herpes virus reactivation, who was Coxsackie B positive or whatever. Because, in my mind's eye, you target the therapy appropriately. We've been subgrouping for forever. I mean, it just seems to me, I would never have used that lymph node protocol on someone that didn't have substantial evidence of immune dysregulation. And so the criteria for that study had 5 different immune markers to be allowed in, and those were the patients we did, and we expanded, and we saw a lot of improvement. So I think we're already there. I think part of the problem we have is that with such a small group of scientists, with such a limited number of well-characterized patients in biobanks, that we haven't been able to validate each other's findings enough to substantially move forward on this biomarker thing. And then I think we're going to be really doing very well. So in my mind, the big issues are, and we need these biobanks, like the one the CFSAC Association is putting together, and I guess Harvard's coming, and we've got a very large one, and the CDC has a very large one. We have those biobanks have to be linked to very clean clinical data sets that show both severity and the symptom clusters. And then you've got to have some biomarkers in that biobank so that you can try to subgroup further. But I think we will very cleanly. I mean, obviously, with these antivirals, we wouldn't ever mess with an antiviral without having a patient we knew had virus. Now, one of the questions that's been raised to me, and people call me up and ask these questions, we're in a hurry, is what if you use some other biomarker to establish these XMRV clinical trials? If you had something that said they were XMRV positive, like serology, but not a viral load, something like that, could you use some of these other biomarkers that track severity of illness as your primary outcome variable and bank your stuff in the freezer so that when we have the appropriate assays developed that we could go back and look and see if we actually affect viral load? I'll throw that question to you.
No, I agree fully with you there. But I think what we can't do is we can't have doctors treating patients and getting anecdotal data that I feel good. I think that's what we have to avoid. I think regardless if there is a biomarker that we feel confident in, then whatever that biomarker is, I think people would be happy to use that. But my point is we just have to avoid this, the current use of antiretrovirals in what is not a clinical setting, and using that as a reason for requesting more clinical trials on antiretrovirals.
In HIV, we used the surrogate CD4 for a long time before we had a valid HIV viral load marker, and they work independent of each other. And T-cell activation was independent of all three, and it's a decent biomarker in that setting. So, I mean, there are some places where we could go. So I think we could work on designing these trials and then hope that we have the assays filtering in as we need them, but key to put the stuff in the freezer correctly. Quickly.
Well, again, this is a point that came up. Is we in the old days, we used to put them in the freezer. And now we've got to know how long we have them in the freezer,
That's true.
How we collect them, and so on. These are things that we would not normally be thinking up front when you're doing something. It's only afterwards when you reach a stumbling block and you start to think about these things. And in hindsight, yes, a cell-associated virus, maybe that is one of the reasons behind this, but we never thought about that up front. And I think the really important thing, as you said, we're now sitting down together and discussing our differences and why are they different, what could be behind the differences we have. And something as simple as sample storage, sample collection, storage, and processing becomes a serious issue.
Have they tried freezing that stuff down slowly in DMSO?
This is really a recently evolving notion.
That. Slow freeze DMSO.
That's what we do for viable cells, right?
Yeah.
It's quite interesting because the prostate
how
cancer
viable.
study that we started without knowing it, we sat for for several hours discussing exactly these issues. What tubes do you want to collect the samples in? Should they have heparin? Shouldn't they have heparin? How should the samples? One person takes a sample, one person ships the sample, and one person processes the sample to the other labs. And things that we know are important, but just were not top of our priority, really are shifting to the top of that priority list.
Mm-hmm.